I'm sorry for that. Hi, my name is Tammy Lytle, and I am the registration manager for the IAS-USA. And today's webinar is on CDC Prep, Clinical Practice Guidelines, Strategies for Ending the HIV Epidemic. And today is March 22nd, 2022. I would like to introduce Dr. Raphael Landovitz, and he will be our moderator. And I would like to turn it over to him for some housekeeping notes.
So thanks, Tammy, and welcome everyone. We're very excited that you were able to join this IAS-USA webinar that will focus on the new CDC PrEP guidelines. It's a really exciting presentation, and we're tremendously honored to have our two featured speakers here with us today, who are going to go over the guidelines and then be able to entertain questions from you all about those guidelines and their implications for clinical implementation of pre-exposure prophylaxis. A couple of housekeeping items, and then I can see that you already can see that there is a pretest question up, so you can begin sort of looking at that. We are going to have, I believe, 2 pretest questions, but first, just want to remind people that this activity is designated for a maximum of 1.25 CME credits, and it's also approved for 1.25 hours of ABIM and maintenance of certification points, and nursing pharmacy and pharmacotherapy credits as well. This webinar is supported from contributions of the folks listed on this slide and IAS-USA, and we are very grateful for that support. We want to remind you that there'll be a recording and slides from this webinar will be available within 1 day after this live broadcast at the website that's listed there. Couple of important points about the poll questions that will appear again in a minute. There's going to be a separate window that's going to pop up on your screen that will show the poll questions. Please submit all your questions as we go through the webinar using the Q&A button. You can use the chat to talk amongst yourselves, but please do not use the chat to pose questions for the speakers. And we apologize in advance if we're not able to get to everyone's questions. We will try and grab those out of the Q&A section before the end of the webinar and get you all responses after the webinar closes if we're not able to answer them live. Okay. So first poll question, and hopefully this will pop up on your screen. How familiar are you with the latest CDC PrEP guidelines? You can choose one of these options. You will see, okay, let's see. We'll give people a minute to respond to that. Okay. Great. So it seems like we have a wide distribution of responses to that question. About 7% of people are extremely familiar with the guidelines. Most people either very familiar or somewhat familiar, and about 10% of people not at all. Okay, so let's move on to the next. Okay. The next poll is hopefully popping up on your screen. How many times have you prescribed a new PrEP prescription in the past month? And there are 6 options. Please choose one. Okay, great. Thank you. So about 60% of people haven't prescribed PrEP at all in the past month. And then we have a smattering of people, including 3% of people who've prescribed it more than 20 times in the past month with us today. So let's move on to the next. Great. So what percent of your PrEP patients stayed on PrEP during the COVID-19 pandemic? And again, 5 choices should have popped up in the poll on your screen. Okay. All right, so again, we've about 50% of people don't have any patients currently on PrEP. And then actually the most common response was somewhere between 20 and 50% and 51 to 75% of people, each 16%, each of those categories, reporting the proportion of their PrEP patients who stayed on PrEP during the pandemic. Let's move to the next. So again, I can't tell you how excited we are to have today Demetre Daskalakis, who's the director of the Division of HIV Prevention at CDC, and also Dawn Smith, who is the Biomedical Interventions Implementation Officer in the Division of HIV Prevention at CDC, to speak to us today about the guidelines and to help us understand them and to take your questions. Demetre, I'll turn it over to you.
Thank you very much, Dr. Landovitz. Nice to see you, Raphi. I'm excited to join you all. Thank you for having us at this important CME event. And I'm excited to be joined by my colleague, Dawn Smith. I will start by just briefly going over the learning objectives. And I'll say, I've been motivated to add a new one, which is the 50% of you that don't have PrEP patients. We're going to, I hope, make it easy for you to figure out how to get some folks on PrEP. So important. But at the end of the webinar, our official learning objectives are to assess HIV trends, prevalence, and infection rates in the US, explain the impact and status of pre-exposure prophylaxis for the HIV prevention goals of the nation's Ending the HIV Epidemic initiative, describe updates to the latest PrEP guideline, including new clinical guidance for the prescription of cabotegravir injections as PrEP, so long-acting injectable. Identify key changes in testing and monitoring patients who are starting or taking PrEP, and list strategies for identifying and engaging patients who could benefit from HIV prevention. And that's specifically talking about the syndemic and status-neutral approaches to delivery of service. That leads us to our first pre-test question. What grade did the U.S. Preventative Service Task Force assign oral pre-exposure prophylaxis for the prevention of HIV? So you can read the slide. You may want to move that box out of the way so you can see it, but grade A is selection 1, grade B selection 2, grade C selection 3, grade D selection 4, and grade 5, it's an I statement. So take a read to see what the different grades are, and we'll give you a moment to answer the question. All right. That's great. So you'll have to tune in to the presentation to see if your answers are correct. Moving on to question 2. True or false? In the United States, the disparity in pre-exposure prophylaxis coverage is increasing between white persons and Black and Hispanic Latino persons. True or false? Please take a moment to answer the question. All right, let's see the answers. Again, we're going to wait for the end to see if you're correct. Next question, number 3. True or false? To increase awareness of pre-exposure prophylaxis, the new PrEP guideline recommends that all sexually active adults and adolescents should receive information about PrEP. True or false? All right, let's see the answers. Excellent. So we'll dive on in and start first giving a frame of reference and talk about the status of HIV in the United States. So in 2019, there were about 34,800 new diagnoses of HIV in the United States. So there's been significant progress in decreasing HIV incidence over time since the height of the epidemic, when it was orders of magnitude higher. HIV in the US continues, however, to be a disease characterized by disparities, many longstanding, and a lot of them follow sexual orientation, race, ethnicity, as well as geographic lines. So though you can see the line is moving, is decreasing, we still have work to do, not only to accelerate the speed of the decline, but also to address disparities. And when we think about disparities, really, HIV, not dissimilar from COVID, really follows in the footsteps of racism, sexism, homophobia, transphobia that have really limited our success for many health interventions in this country. So when you look at the snapshot of disparities, there's a higher HIV incidence among gay and bisexual men. Black Americans have a higher incidence, as do Latino Americans. There are larger gaps in PrEP coverage. Specifically, Black Americans and Hispanic or Latino Americans are experiencing gaps in PrEP coverage compared to white counterparts. There are lower rates of viral suppression. So American Indian and Alaska Native persons have lower rates of viral suppression, as do Black or African American persons. There's a higher HIV prevalence among men who have sex with men and transgender women. And we're seeing more HIV outbreaks among people who inject drugs, an area that really was a great success, but those increasing outbreaks threaten the success we've made in those populations. So beyond the individual groups that have disparities, there's also a geographic disparity. And from the eagle's view of this map, you can see areas that are darker, that sort of darker blue color, are actually experiencing higher rates of diagnoses. And you can see that in terms of a region that's pretty consistent, the South has pretty significant higher rates of HIV diagnosis than most of the rest of the country. So one of the strategies, which is in itself an equity intervention, is to hyper-resource areas with increased HIV activity. So it really is letting our data lead us to areas of the country where adding more resources could potentially accelerate the declines in HIV incidence, and then ultimately lead to the point where we can say numerically we have ended the HIV epidemic from the perspective of forward transmission and increase of prevalence. When you think of the ending the HIV epidemic in the US, I like to think about it as the capital, the big letters EHE, which are really what we're all doing every day, as well as the Ending the HIV Epidemic Initiative, which is a multi-agency federal initiative that has very specific goals of reducing new infections in the United States by 90% by the year 2030. So with EHE, CDC and other federal partners are working to accelerate progress by delivering key prevention strategies in innovative ways, hyper-resourcing areas hardest hit by HIV. At the end of the day, there are 4 pillars or 4 strategies that we all have in common. Again, with the capital EHE as well as the EHE initiative, it is diagnose all people with HIV as early as possible, treat people with HIV rapidly and effectively to reach sustained viral suppression. That's the notion of undetectable is equal to untransmittable, so, or U equals U, treatment as prevention. Prevent new HIV transmissions by using proven interventions. This is what we're going to talk about today, specifically PrEP, but we can't say PrEP without including syringe service programs, since they are so effective in preventing HIV transmission among people who inject drugs as well. And then finally, response, which is our early warning sign of identifying clusters and then acting on them with a response to identify gaps in HIV treatment and prevention, address those gaps to prevent future outbreaks in the same area. So today, as I said, though there is a lot of exciting conversation to be had about all 4 pillars, we're going to focus down precisely on PrEP and talk about PrEP access, uptake, persistence, as well as updates to our guideline. So I'll also say that PrEP is one of the things that allows us to have a vision that's called status neutral. So a status neutral approach to care really begins with the HIV test. If somebody tests positive, they can enter a treatment pathway with culturally inclusive, responsive quality care and all the support services that they need to maintain their health and to stabilize their social situation. When all of that happens, they enter that pathway, and if they stay engaged and they go on medicines, they become virally suppressed and they're unlikely to transmit HIV. Similarly, that HIV negative test has a lot of power. And it's a power I really want to emphasize as we approach a strategy to really create an environment where the status of a person doesn't matter, but rather the services that they need and the care that they need drives the system. So that HIV negative test is a great opportunity to provide supportive services, et cetera, that lead people to a prevention pathway. If people are assessed and reassessed and require PrEP, they will go on pre-exposure prophylaxis, and it is unlikely they're going to get HIV. So really braiding these two together into one system where status matters less than the services that need to be delivered really addresses stigma and also creates efficiency to be able to achieve a vision where we are able to end HIV with equity and respect to individuals based on their whole person needs, as opposed to just responding to their HIV status. Now, we can't really say PrEP without talking about treatment as prevention, because that's the other part of that status neutral equation. We know that a person with HIV who takes HIV medicine as prescribed and gets and stays virally suppressed or undetectable can stay healthy and has effectively no risk of sexually transmitting HIV to HIV negative partners. You can call it treatment as prevention. Some people refer to it as U equals U. The message is clear. Treatment is a powerful intervention, but PrEP is a critical part of the equation as well. So let's talk a bit about where we are with PrEP coverage and some of the challenges and opportunities we have to move faster and better with this critical intervention. So despite overall progress toward ending HIV continues to affect some groups severely and disproportionately. Rates of new infections among Black people are over 8 times as high, and among Hispanic Latino people, almost 4 times as high. Think about that map that I showed you at the very beginning. So really there are stark disparities. Those also exist in the universe of PrEP. To end the HIV epidemic, we've got to scale up HIV testing, make sure people with HIV are linked to care and getting treatment, and ensure equitable access to HIV prevention, including PrEP. So for everyone who could benefit from PrEP. However, current PrEP coverage remains uneven across racial gaps and ethnic groups, age groups, and for transgender persons. It is important to note the disparity is increasing between white persons and Black and Hispanic Latino persons. Black and Hispanic people account for the majority of people for whom PrEP is recommended, but have the lowest rates of PrEP use among all racial ethnic groups. Preliminary CDC data shows that only 8% of the nearly 469,000 Black people who could benefit from PrEP received a prescription in 2020, and only 15% of the nearly 313,000 Latino people who could benefit from PrEP received a prescription. So it is critical to note that our nation will only realize the promise of PrEP if people can access it and use it. It does nothing if it sits on the shelf, especially if it just sits on the shelf for populations who could potentially benefit from it greatly. PrEP coverage is also unevenly distributed among people based on sex. Among people for whom PrEP is recommended, PrEP coverage was about 3 times as high in 2020 among males as it was among females. Now remember, cisgender women represented 19% of new HIV diagnoses in 2019. So addressing this imbalance is critical to achieving adequate PrEP coverage and to end the HIV epidemic evenly and not just in one population preferentially. So one of the important things that we need to do is increasing the number of PrEP providers. And there are a lot of things that are happening that really make now the time to incorporate PrEP deeper into primary care. So the US Preventative Services Task Force assigned a grade A recommendation for primary care preventative care for PrEP. Following that, CMS released FAQs that supports that both medications and the clinical services that support PrEP should be covered by insurers without out-of-pocket costs to the patient. So that means no copays. PrEP is a highly effective primary care intervention, but to get it to the world, we need more providers to educate their patients about PrEP and to prescribe it. So who are PrEP providers? So I think the answer on this slide is everyone should be considered a PrEP provider. Primary care providers are critical in this equation. PrEP provision is not that different than doing good tobacco cessation counseling, harm reduction for other behaviors. So it really fits in the primary care lexicon, and we're going to talk more about that later. Definitely sexually transmitted disease clinic providers or sexual health providers, important in the mix. Also, providers who do women's health specifically are critically important. HIV care providers, they know how to use the medicines, they have the experience, but sometimes they don't always have the access to people who could benefit from PrEP. So though they're an important part of the mix, we need to think expansively about a PrEP provider and thinking about that status neutral approach, thinking about drug treatment providers as well, where those services should be kissed with HIV treatment and prevention as well, since those populations overlap so significantly. Now, there are increasing numbers of PrEP providers in the US. So we have made progress. If you look at the map 2014 compared to 2019, so those bigger circles mean more PrEP providers. There were 66,000 PrEP providers in 2019, and that compares favorably to just under 10,000 in 2014. When you look at the mix, 68% were physicians, 30% were nurse practitioners or PAs. Now, 4% of all active providers have prescribed PrEP. Now, this is an area where we could do a lot better. But of those providers, 13% were family practitioners and 34% were infectious disease physicians. So lots of room for us to increase PrEP uptake and knowledge among primary care providers as well. Now, this one is really a call to action. 50% of PrEP patients were prescribed their PrEP by 3% of PrEP providers. Imagine if we could move that equation a bit more toward more PrEP prescribers prescribing PrEP at all. We would see an increase of PrEP provision, and we would get closer to our goals to achieve our ending the HIV epidemic visions. So with that, I will hand over the mic to Don Smith, who will take us through some of the changes in the guideline. Don.
Hi, good afternoon. Next slide. I'm going to talk to you a little bit about the new PrEP clinical practice guidelines. So many things did not change from the 2017 guideline. Specifically, we made no changes to the indications for PrEP use, the frequency of follow-up visits for oral PrEP, or the schedule of HIV and STI testing for oral PrEP. Next slide. One of the important changes in the new guideline is a new recommendation that all sexually active adult and adolescent patients should receive information about PrEP. We added this recommendation because of many studies showing that many people who could benefit from PrEP don't know that it exists. So we wanted to encourage providers to offer PrEP as a core primary care service in order to reduce the missed opportunities for PrEP provision, and we'll talk a little bit more about that later. We also wanted to make this recommendation to increase the knowledge of PrEP among potential users, both so that they could consider whether they want to use PrEP at the time that they're informed about it, or at some time in the future when they might feel it's more appropriate for them. We also want them to know about it so that they feel free to ask about PrEP. We want to increase the knowledge of PrEP in the broader community, and this is important for two main reasons. One is people who themselves don't necessarily feel PrEP is right for them may have friends, family members, others that they know who they think would benefit from PrEP, and they need to be able to disseminate that information to those folks. The other reason is that we hear sometimes from PrEP patients that members of the community that are important to them, family and friends, don't understand about PrEP use, mistake it for treatment for HIV infection. And in order to increase support for PrEP use, we need to have the broader community more aware of what PrEP is and what it's used for. Next slide. Clinicians asked us in a survey that we did about the 2017 guideline to take the indications for PrEP and instead of putting them in tables and boxes, to put them in a flow diagram, which would be easier for them to follow. I'm not going to walk you through each element of this, but that's basically what we did here. And what you should also notice at the bottom is that if you have indicated risk factors for acquiring HIV infection, as you go down this algorithm, you land on the dark green boxes which say prescribed PrEP. So these are patients for whom PrEP should be offered, recommended, and prescribed. But then there's a lighter green box for people who don't identify any particular risk factor. And those are patients for whom you need to be sure they're aware of PrEP. And if they ask for PrEP, if they come to the clinic asking, or if they ask after you discuss PrEP with them, they should also be prescribed PrEP. People who believe that PrEP will benefit them may know more about their risk behaviors than they're willing to disclose in a clinical encounter. And we should trust patients to know what's in their best interest. Next slide. This is the same kind of algorithm, but for persons who inject drugs. Next slide. We then provided, as we did in the 2017 guidelines, a table that summarizes our recommendations about daily oral PrEP. And there were only a couple of things that changed. Newer data has demonstrated that persons who have estimated creatinine clearance that is at a normal level, but above 90, and who are less than 50 years of age when they initiate PrEP are very unlikely to develop changes in creatinine that are concerning. And so for these patients, we say that no longer to assess creatinine every 12 months, but every 6 months. The other thing we did was we removed the pregnancy testing from the follow-up visits. It should only be done if indicated, now that we're very sure that oral PrEP is safe and in fact recommended for many women who are pregnant. Next slide. We also included a new section about prescribing event-driven PrEP using the 211 regimen for adult MSM and transgender women. While CDC does not recommend this, and the FDA has not approved this regimen, IAS-USA has recommended it, and so have a couple of other jurisdictions in the US. And so we felt it was important to describe it in the guidelines so that practitioners who had heard about it would have prescribing information about it. So we think it's really important also to talk to 211 patients about anticipating when they will be switching and advise them how to safely switch between daily and 211 dosing. This is partly based on reports from clinicians that patients frequently switch without HIV testing to confirm that they're HIV negative, and this can be problematic. Next slide. We added a summary table about cabotegravir injections for PrEP, and the STI screening, for example, is on an every 4-month schedule to match the every 2-month injection visits, rather than the every 3 months that's used for oral PrEP. And we changed the HIV testing recommendations to confirm negative status, both at initiation and follow-up visits, which I'll go through in a little more detail in a minute. Next slide. So based on data from the HPTN 083 and 084 studies of cabotegravir for PrEP, which included an arm that the control arm was a Truvada arm. We now have 2 testing procedures for determining HIV status. One for starting or restarting PrEP for persons who have no recent antiretroviral exposure. And in this case, the only change we made from the 2017 guideline was to lower the HIV-1 RNA threshold for retesting for possible false positive results. In the 2017 guidelines, we had used a level of 3,000, which is consistent with the HIV treatment guidelines. But on further discussion and review of data in the 2021 guideline, we reduced it to 200. The second algorithm is for restarting or continuing PrEP for persons who had recent antiretroviral use. And this new algorithm relies on qualitative or quantitative HIV-1 RNA assays rather than combination antibody antigen assays. Next slide. You can see this data from the HPTN 083 trial, in which in the cabotegravir arm, if you look at incident infections on cabotegravir, there was an average delay, median delay of 98 days between when the antigen antibody test was positive at the site at a clinical visit, and when it could be detected in a research lab that tested stored specimens from previous visits. And in the FTDF arm, you can see that there was a similar delay, but of much shorter duration. It was only on average 31 days. Next slide. So on the left, you see the normal acute infection kind of diagram that we're all used to, in which in the absence of antiretrovirals, you have an HIV-1 RNA spike that's followed by a rise in antibody titers, so that initially you will only detect HIV infection using NAT tests, and later you will be able to detect it using an antibody test. On cabotegravir, there are a couple of things that appear to be very different. Number one is, while HIV-1 RNA is present before antibody, the time between the detection of an HIV-1 RNA and the time detection of an antibody titer is much, much longer. And in fact, in this slide, it's really undefined. It can depend on a number of factors, and so it's not possible to create a specific timeline. The other thing is that the HIV-1 RNA levels can fluctuate on the qualitative assay. So it's been seen in some cases that they're detectable at one visit and then not detectable at a second visit and then detectable again at another visit. So there's a lot we don't know about detecting acute HIV infection in persons who are on longer acting agents. Next slide. Demetre?
Thank you. Sorry about that. I was on mute. So
Okay.
Thanks, Dawn. So beyond just the benefits of pre-exposure prophylaxis from the perspective of preventing HIV and reaching our goals of ending the HIV epidemic, PrEP is also a really amazing opportunity for primary care. PrEP is readily integrated into primary care practice. So I know that there are a lot of demands and there's a lot to fit into a very short number of visits, but it is so similar to some of the other strategies that we have to prevent other diseases, that it fits right on in. So some examples of similar interventions are metformin for prediabetes, statins for cardiovascular disease, oral contraceptives for pregnancy, and anti-malarial medicines for travelers. So when they're going into a malaria zone, they can start anti-malarial medicine. So if they have a time period in their lives where they're at increased risk for HIV, it could be a great time for PrEP. So if patients test HIV positive or as appropriate based on clinical judgment, beyond the sort of PrEP intervention, it is also a chance to expedite people's connection to care from prevention into treatment in a very sort of streamlined, easy fashion. So just to sort of further highlight the point, when you look at the number of people needed to be treated to achieve the prevention end goals of certain interventions, you'll see that PrEP really does compare favorably. So you'll see statins and MI prevention, you need to treat 60 people to prevent MIs, an ACE inhibitor, 56 people to prevent death, metformin, about 14 people for diabetes prevention. And when you look at PrEP among men who have sex with men, treating 37 people means preventing an infection. For heterosexual women in a serodiscordant relationship, PrEP would allow, you would have to treat or give PrEP to 15 women to be able to prevent an infection. And for Black men who have sex with men, you'd only have to treat 11 with pre-exposure prophylaxis to prevent an infection. So if you size it up next to the things that are sort of our primary care dogma, this fits really into that very well into the primary care dogma. Also, there are so many missed opportunities that we have, and this is just a short list. So in New York City, among seroconverters in the years 2012 to 2017, 42% had a prior negative HIV test visit without provision of PrEP. So imagine if part of the story of an HIV test, part of the negative is to teach people about PrEP or make an offer. In South Carolina, among seroconverters 2013 to 2016, 25% had a diagnosis of gonorrhea or syphilis, clear markers for potential future HIV infection at a prior healthcare visit, but they didn't receive PrEP. So imagine those missed opportunities if those individuals would be offered or talked to about pre-exposure prophylaxis. In Virginia, among patients with indications for PrEP, 35% experienced delays receiving PrEP ranging from 6 weeks to 16 months. So making it really a part of the fabric of what we do, as well as streamlining systems, is a critical step in preventing those missed opportunities. And among adolescents in Alabama at a primary care center, 44% had a PrEP indication and none were offered or prescribed PrEP. So following that guideline and having conversations about PrEP, really a critical step in moving the needle to make sure that we have improving PrEP coverage in the US. Now, I'm not going to go over this entire grid, but the whole point of this is that, that PrEP is in many ways a gateway to primary care. And I think that there are some great studies and articles that have been written about this. It's only a visual aid. I'm not really going to go over them, but regular visits for PrEP care are really an opportunity to provide a broad range of primary care services. That includes vaccines, screening for smoking or intimate partner violence, mammograms, screening for prostate cancer, the list goes on and on. And again, I think though there is challenge in that there's only so many minutes in a visit, this one is pretty important. So integrating it into the repertoire of things that we know are also important in preventing other diseases makes a lot of sense. I also want to take a moment to tell you about some resources that we have before we move on to our Q&A that may be helpful to you. So first, there is the CDC HIV campaign called Let's Stop HIV Together. So this is a really amazing status neutral campaign that is both consumer facing and clinician facing. So it really provides you some really significant resources that could be helpful in communicating about PrEP, things that may be helpful in your office. They focus on stigma, patient care, testing, prevention, and then also treatment and care in general. So please check out our website if you want to see more about these resources, which are really helpful. Additionally, we have really important resources for clinicians, and I want to emphasize all of them, but one very specifically. So I think Dr. Smith presented some pretty complex testing, and sometimes it's hard to figure out what tests mean, especially for someone who is exposed to an antiretroviral. So I want to plug our PrEP line, which is 855 HIV PrEP. It's toll-free, and it's a great place to call if you have an ambiguous test result that you want to understand better or need assistance interpreting. Additionally, we would ask you to call if you have a person who acquired HIV while prescribed PrEP. There are also really important administrative support available from NASTAD, which is a billing and coding guide, which really teaches you like the best practices for billing and coding for PrEP, and a PrEP healthcare coverage calculator that really looks at optimal strategies for covering individuals so that they can get on PrEP. Footnote again, there is a grade A designation for PrEP by the Preventative Task Force. So that will become a bit more straightforward. Also important to know about HIV Nexus, which is CDC resources for clinicians about HIV. So it's closely tied to our work with Let's Stop HIV Together, but really great information as well as good access to a lot of our clinical facing resources. So it really serves as a one-stop hub for those resources, contains latest research and information on HIV prevention, screening, and treatment, provides access to free CME programs, and highlights guidelines such as the PrEP guideline, as well as recommendations. It also provides easy access to patient education materials if needed. And also important in the discussion is how to help patients pay for PrEP. So again, USPSTF grade A recommendation and our CMS FAQ follow-up really makes the point that commercially insured patients have no out-of-pocket costs for medication, clinical care, and lab tests. So though there may be situations locally where they're still sort of getting up to speed with this, this is the end state that we're expecting for oral PrEP. Also, for uninsured folks, there are strategies. So one is to identify an insurance product that works for them through healthcare.gov. And then there are also strategies for free medication. And that includes the Ready, Set, PrEP program available at hiv.gov, and that is for oral PrEP medication, the Gilead Medication Assistance Program, and the ViiV Medication Assistance Program. So those are the producers of the drugs that are approved for pre-exposure prophylaxis at this time. So I'll say that we have really an unprecedented opportunity to end America's HIV epidemic by testing, by treating, by using PrEP optimally for prevention, as well as upscaling SSPs and working with public health to respond to clusters and outbreaks. We are in a place where, despite the lack of a vaccine or a cure, we are able to envision a point where HIV could be an epidemic that is under elite control. And all of the good things that flow from that, with less suffering and death related to HIV-related causes, and also the impact that HIV has on people's quality of life and other comorbidities. So it's a very exciting time and a very important time to motivate action to achieve that vision. I think we're back at our pre-test questions. The post-test questions. So just one more time, what grade did the U.S. Preventative Services Task Force, the USPSTF, assign oral pre-exposure prophylaxis for the prevention of HIV? Grade A, grade B, grade C, grade D, or an I statement? All right, let's take a look. Well, I think that is a significant improvement. We did only say it 6 times during the talk, so thank you so much for your attention. That's awesome. Post-test question number 2. True or false? In the US, the disparity in pre-exposure prophylaxis coverage is increasing between white persons and Black and Hispanic Latino persons. True or false? All right, let's take a look. Excellent. True is the correct answer. And then on to post question number 3, true or false? To increase awareness of pre-exposure prophylaxis, the new PrEP guideline recommends that all sexually active adults and adolescents should receive information about PrEP. Let's see it. And again, 100% have selected the correct answer. Thank you very much. And I think I'm handing it back off to Dr. Landovitz, who is moderating some of our Q&A.
So thank you so much, Dr. Daskalakis and Dr. Smith, for that amazing presentation. Very helpful, very thought-provoking, very informative. We have a real variety of questions for you both in today's Q&A. I'm going to try and sort of summarize general groups of questions so we can get through as much as possible. The first sort of general set of questions was this around this real call to action of integrating PrEP services into primary care. And a lot of people were very grateful to you both for showing that comparison of the numbers needed to treat compared to other more standard primary care interventions. And some people were musing about this really comes down to a lot of primary care providers' uncomfortability, if that's a word, with talking about sex. And some people were raising the additional challenge, not only about people's sort of own discomforts about bringing up sex, but fitting everything that's required into a 15-minute visit. Do you have any guidance for primary care or generalists who have very limited time to accomplish an inordinate number of acute care, chronic care, and preventative care type issues, and trying to fit this in is, I think, appropriately a concern a lot of people have?
Don, do you want me to go first, or do you want to go?
So let me just start, since I'm a family practitioner. I think there's a couple of things. First of all, I think it's too simple to say that practitioners are uncomfortable talking about sex. They talk about sex with patients all the time. They talk about birth control. They talk about erection medications. They talk about all kinds of things. I think it is true that there is discomfort in asking detailed questions about sexual behavior. Fortunately, to prescribe PrEP, you don't need to ask a lot of questions. I don't need to know what position you're in, and I don't need to know how many partners you had in the last month. But I think what we do need to do is help them ask the questions that are most relevant for HIV acquisition. So for example, we know that many MSM don't volunteer to their providers that they are MSM, and many providers don't ask. And so just being able to get that one question into some point of care for primary care patients would be tremendously helpful. So I think we need to streamline what we're asking the primary care providers to do, and then we'll be able to convince them to do it more effectively. The other thing is that there's a literature about what primary care providers need in order to adopt a new primary care practice. And there are a couple things that we can rely on. One is they have to believe that the practice is something they should be doing, something that's in their kind of sphere of control, that's in there, that other providers of their type are doing. And so I think the kinds of comparisons we made to other primary care practices can be helpful in explaining why we think PrEP is a primary care practice. The other thing, though, is that they're more likely to adopt a new practice if they think what they're doing is going to make a difference. And I think if we can talk to them about this idea of missed opportunities, that, that any patient in your clinic who develops an HIV infection and for whom you've not discussed PrEP is a failure on the part of your healthcare system, that we really need to think about what we know motivates primary care practitioners to adopt new prevention procedures. Over to you.
I'm just going to add a couple of thoughts, like mine are a bit more just sort of brass tacks practical, which is I remember when I was practicing in New York City, there was a new recommendation or a new actually guideline locally that we would screen for post-traumatic stress disorder. So we all had to sort of learn how to put questions in to our encounters to cover PTSD, really to think about doing better trauma-informed care. And that was a new practice for me. I wasn't doing that sort of in that format in the same way. And it was amazing to see how much PTSD I uncovered by adding it into my practice. So I would say this is not dissimilar. Sort of practicing how to take a very brief sexual history is going to be, I think, remarkable in terms of what you learn and how many folks you have who may benefit from pre-exposure prophylaxis. So my first answer to the question is practice, practice, practice. The other part that I feel is something to think about is if there's an overall sort of, our guideline says, think of, offer this to, or discuss it with everybody who's sexually active. There could also be other strategies that involve waiting room level checklists where people can answer if they're sexually active, and that should then trigger some education about pre-exposure prophylaxis. Now, that doesn't replace comfort, talking about sex, drugs, and rock and roll. I think that that's something that we all have to get better at, but the only way to do it is to put it in your practice and try, which is also true for prescribing PrEP. I feel like once you actually flex that muscle and do it, it's a muscle that won't atrophy. It's going to get stronger because of the fact that populations are living within your practice that you may not be detecting who could benefit from the intervention. I'll hand it back to you, Dr. Landovitz.
No,
Wait a
thank
minute, let me,
you.
can
Dawn,
I
go
just
ahead,
add one thing?
please.
The National Clinicians Consultation Center, which operates the PrEP line, also has a mini mentoring program for new PrEP providers. And we know that information alone doesn't change behavior, that the ability to have ongoing interaction when you're learning a new procedure can be very helpful. So providers should also take advantage of opportunities like that.
No, thanks, Donna. And I can't emphasize enough how useful that PrEP warm or hotline is, particularly when you have confusing situations clinically or results that are difficult to interpret, which is likely to only continue with these new guidance around an expanded testing algorithm that we'll be talking about more. So let me move on to oral PrEP. A lot of questions about the use of oral PrEP. One that you had sort of alluded to, Dr. Smith, that I would love to hear more about, and I think so would the audience, is you mentioned pericoital 211 on-demand PrEP with TDF FTC, and that it wasn't recommended by the US CDC, but it is by IAS-USA and a number of other regional guidelines by the WHO, et cetera. Can you talk a little bit about what is preventing or what the concerns are from the CDC from endorsing that strategy?
I think there are a couple of things. Number one is, as a federal agency, we generally don't recommend off-label use of things when there are on-label options. It's kind of a policy position that CDC has. And I think the fact that the data were never presented to the FDA, so that they were never given an opportunity to make a recommendation, has left us in this situation. I think we included it in the guidelines because we recognize that off-label prescription is a very common thing in the US. And we wanted to recognize that people who wish to prescribe off-label should have some guidance about how to do that. So although we don't formally recommend it, we are including it in the guideline.
Thanks, that's a very helpful perspective. Can I ask also, people are wondering about tenofovir alafenamide-based PrEP and thoughts that you have about its use compared to daily oral TDF-based PrEP, and in particular, any thoughts that you have about off-label use for cisgender women who are having exclusively vaginal sex, or for cisgender women who also report rectal intercourse as well?
I think we're in an era, we're blessed to be in an era where if used as prescribed, we now have 3 agents that are greater than 95% effective. And so when we talk about comparing effectiveness across them, we're really talking about small numbers. Basically, FTAF, FTDF, and cabotegravir are all extremely effective. But oral agents have a special adherence problem that reduces their effectiveness in practice. I think in terms of the FTAP question in women, again, it's similar to the 211 question. It is not recommended because it's not approved by the FDA because there were no trials done in women. And unfortunately, the one trial that would give us some data about FTAF in women is the lenacapavir trial, which is now on hold for other reasons. So it's going to be a while before we get that information. I think providers can prescribe off-label when they think it's in the patient's best interest, but we can't recommend it because it's specifically not recommended by the FDA.
Right, and it's indeed unfortunate that the studies that are going to give us that really critical data now are being held up for unrelated issues. So that's going to be delayed even further. Dawn and Demetre, could you talk a little bit about, I think, perhaps the largest elephant in the room in the new guidelines, both in the Q&A today and in the questions that were submitted before today's webinar, is people really struggling to understand the recommendation for RNA testing as part of oral PrEP follow-up. I think people are less concerned about recommendations for use of an RNA, particularly in a high incidence population before starting a PrEP based regimen of any type, particularly if there might be recent exposures, but particularly with regard to oral PrEP and the quarterly HIV assays that are used for follow-up. Could you sort of walk us through the guideline panel's thinking about this change in recommendation?
I think there were a couple reasons for it. One is the data from the FTDF arm in 083, which corresponds to some earlier data from the Partners PrEP trial showing about a 30-day delay in detection in patients who became infected while on FTDF PrEP. There was also another study of acute infection in MSM who acquired HIV infection in Thailand, in which they looked specifically at how the antigen antibody test performed, and it did not perform particularly well. It missed many of the acute infections. And so recognizing that we have not the same quality of data for tenofovir-based PrEP that we have for 083, where there was a systematic way of going back and looking to see what was the actual timeline for earliest detection of infection. And recognizing that we want to detect infection in oral PrEP patients as early as possible as well, for a variety of reasons. It was decided that we would also go with a qualitative RNA assay for patients on follow-up. It's also exacerbated by the fact that with oral tenofovir, we hear a lot of discussion from providers and in the community that there's a lot of inconsistent use. So there's a lot of opportunity for infection followed by the use of an antiretroviral, which can suppress the acute infection virology that we're used to seeing. I think this is an area where we're in only a small, we have not enough data. And as we get more experience, more studies are done looking back to detect the earliest infection time in oral PrEP users, we will have a better sense of whether we can back off this recommendation. But that's the justification for including it in this guideline.
Yeah, thank you, Dawn. I've struggled with this issue personally, and you and I have talked about this and feeling like maybe there was an over interpretation of the 083 findings. But that aside, a lot of people on the chat today are concerned about the complexity of implementing that, the potential for false positive rates with RNA, and the costs that would be associated with it, all being barriers that are antithetical to this push to make PrEP easier and more accessible, particularly to primary care providers. Could you talk a little bit about how that balance is in your mind?
Well, there's two things. First of all, we recommend that you do both an antigen antibody test and a qualitative viral load, and that if patients have a negative antigen antibody test, you can continue their PrEP while you're waiting for the qualitative viral load. So we're not suggesting that people withhold PrEP in order to get a qualitative viral load test. And I think PrEP, when we think about the patient perspective, the most important thing is to protect people from HIV. And so if you can't do a qualitative viral load and you can do an antigen antibody test, you should do that and give the patient PrEP. We're recommending what we think is the best way to provide PrEP, but we're not suggesting that sites for whom that's not feasible should not offer PrEP. That would be a very wrong interpretation. In terms of the cost, there are a couple things going on. One is the USPSTF is reviewing the cabotegravir data, trial data, and will update its recommendation for PrEP to include a recommendation about cabotegravir. I would guess, I mean, I don't know this, but I would guess that they're going to also give it an A grade recommendation. And if it gets an A or a B grade recommendation, then it will be covered with the no cost provision that's currently in place for oral PrEP for commercially insured persons. And that will include covering the RNA testing. We also have making a recommendation makes it more likely that insurers will cover the RNA test. In the absence of a recommendation by CDC or others, that's very unlikely to occur. So we're thinking that over time, this will become more and more a procedure that's covered by insurance, and so it's not a financial burden on patients or clinics that are providing this service. In addition, CDC has made available some of its funding to jurisdictions available to cover laboratory costs, among other things. And so there may be multiple avenues for meeting the cost. Because we're only a few months into it, there are still a lot of problems. But I remember the days when we did the 2014 guideline, and we said you needed to do creatinines before you started people. And the STD community said, we can't do creatinines. They're too expensive. We don't have the equipment. You know, we can't do it. And jump forward now, and there's no complaints about it. Everybody has figured out how to do creatinines and how to pay for them. And I would guess that as we move forward over time, this will become less of an issue.
So Dawn, can I ask, is it fair to say that at least some of the thinking in the CDC's taking this position has been, number one, to set a very high bar to make insurers cover what's potentially needed, and to also spur innovation and drive the field forward towards advancing sort of where we think this is going, particularly with longer acting PrEP in terms of more sensitive, potentially point of care, inexpensive diagnostics?
No, we don't. The guidelines committee does not take any of those things into account. We're solely focused on what we think are the best recommendations for the clinical benefit of the patient. And it, you know, I'm just explaining to you that it has these other downstream effects, but we didn't make the guidelines to get to a particular insurance coverage result or to generate a particular research question.
Understood, understood. There are a couple of questions in the chat that are referencing your comments on United States Preventative Services Task Force and the A-grade rating. And some people are noting that there are still private insurers who are giving pushback about covering the cost of office visits and the lab tests. Do you have any guidance for people who run into that particular scenario?
Yes, I think what we've heard is that the best thing to do is first to appeal it, but then secondly to report such cases to your insurance commissioner, because CDC has no enforcement ability for any of these things, but insurance commissioners do.
No, that's great, Dr. Smith, because I think a lot of people feel powerless in the face of these rejections. So just having a pathway that you would at least can see visibility towards having some teeth is really helpful. Just in the interest of time, I do want to make sure we have time to talk about injectable PrEP. And you know, one of the most common questions that's coming through the chat and the pretest questions is, so you have someone who's new and coming in and starting PrEP de novo. You know, we have the results of 083 and 084 and superiority in those studies. How do you decide what kind of PrEP to offer someone?
Demetre, you're a PrEP provider.
I think it's so similar to the conversation, Rafi, that people have around contraception, which is that different strategies work for different people. And I think that, as injectable becomes more readily available, because that's going to take a bit of time, but as it becomes more readily available, ultimately, it becomes an even more exciting conversation about making sure that the intervention fits the person's life. So I think for some people, in my experience, the notion of having to go in for an injection is something that they don't want to do, while others would rather never take a pill again in their lives. So I think that there's really the opportunity now to be able to have a discussion about what fits better in their lives. And so ultimately, I think that it's going to, and I guess the spoiler alert is, if everything goes well, which I think that there are a couple of things that may be slowing down some of the newer technologies, there may be even more delivery options like implants and all of that will make it an even more sort of robust landscape of interventions that people could pick. So I think, it's really about what's available at the time and also what people's preferences are and how it fits their life.
Thanks, Demetre. I just want to echo that. I think what people want and what they're willing to use needs to really drive the recommendation, right? I mean, I think we're all sort of excited to work through these issues of the availability and coverage to make that choice a realistic choice, right? Because when there are finances and availability options, then it's not really a choice, right? And it's really incumbent on us to get through that bureaucracy to make it so it can be a choice. A lot of people have been concerned that some of the way the injectable prep is being operationalized get to one of those exact issues, that there are these multiple models. It's part of the medical benefit, not the pharmacy benefit. And so some insurers are mandating that small clinics do this buy and bill thing where they invest resources up front to have the drug on the shelf. And that's not feasible for a lot of clinical sites. A lot of universities refuse to do it. And so is there anything the CDC can envision doing to help prevent or discourage those sorts of practices that are just going to get in the way of implementation?
Don, I'll start and then you can chime on in as well. I think one of the challenges is again, sort of working across and beyond CDC, because a lot of the sort of issues revolving around the regulation of the drug as well as the billing of the drug are sort of living outside. Now, with that said, I think we have opportunities to make sure that as we hear about what the barriers are, we identify strategies to improve and also do implementation science about, how people make their decisions for PrEP, but then also like what certain settings may be most appropriate for PrEP use. So I think things are coming down the pike to better understand that and identify strategies to address some of the regulatory barriers that are inherent in the way that the drug was approved. Don, I'm not sure if you have anything to add there.
No, I think we're still at the stage, again, given that we're only 3 months post FDA approval, we're still at the stage of trying to understand from our clinical partners what the barriers are and what strategies they're putting in place to deal with them. We're hoping that we can build on the experience with Cabenuva for treatment, to kind of adopt some of the things that worked for introducing that into clinic settings, to introduce Apretude for PrEP.
Dawn, I just want to come back to something that you mentioned that I think is really critical, but often gets lost in looking at the guidelines, which is that if RNA testing isn't available or isn't feasible, that is absolutely not an indication to not provide PrEP. That's a lot of nots, a lot of double negatives there. But am I hearing you correctly? And can you please say that again if that's what you meant?
HIV testing to determine whether a person is negative or positive is an absolute requirement for starting or continuing any form of PrEP. What assay you use, what assay you have available, is a different question than can I start PrEP without assay A, B, or C? And the answer is, as long as you have one of the better assays, whether that's an antigen antibody test, whether that's sending it to the lab, whether that's doing a point of care antigen antibody test, as long as you have a reasonably sensitive test, then you can go ahead and provide PrEP. And if you can get the qualitative viral load, then do it. But if you can't for some reason, then you still need to provide PrEP for the person's health. It's similar to the statement that we made during the COVID epidemic when people couldn't get to the lab and they couldn't get to the clinic. And although oral HIV tests are the least sensitive tests and are not recommended for PrEP in general, during the time of lockdown, we said, if you have no other option, use the oral test. And it's similar to that. It's not, I don't want people to misunderstand and say you don't need an HIV test because I can't do a qualitative viral load.
I think that's a very helpful perspective. Thank you for that. People are wondering if you could reiterate also the STD or STI testing schedule when using cabotegravir PrEP? Because obviously there's a non-quarterly schedule, and people just want to make sure they heard you correctly, that it's recommended essentially on 4-month intervals, i.e. every 2 injections, rather than quarterly as it is with oral. Is that correct?
That's correct.
Okay, and there was also a question about, for heterosexual individuals and different between males and females, the rationale for different schedules and types of STI testing.
Well, that's true in for both tenofovir and for cabotegravir, and that's simply based on the data that we have so far of the incidence of STIs in different populations. So
No, I think that's really helpful.
The incidence is lower in heterosexual women than it is in MSM. And so we recommend more frequent testing for MSM than we do for heterosexual women.
Do either of you, and Demetre, I know you need to run in a minute, but do either of you have thoughts on the workflow for injectable cabotegravir in clinical settings? For example, the requirement before starting for a 4th gen plus an RNA, do you wait for the result from that 4th gen test to begin providing cabotegravir? Do you send both tests and begin cabotegravir? And then similarly in follow-up, when you get to the injectable portion, if you're using an oral lead-in, do you delay an injection for any of those results to come back? Or do you give the injection simultaneously with sending that testing? Just people wondering about the operationalization of those testing recommendations.
So for initiation of PrEP, for both oral and for cabotegravir, we have always said you need an HIV negative test result within a week of starting, within the week prior to start initiating PrEP. And I think in cabotegravir, that's especially important because you can't take it away. I mean, with Truvada, you could stop somebody pretty quickly if the lab test came back positive. And so I think that's still our position. So if you have a patient, you're discussing PrEP with them, they haven't had an HIV test, and they want to start cabotegravir, you sort of have 2 options. One is if you have a rapid antigen antibody test available in the clinic, you can do that. Draw the blood for the qualitative, send it to the lab, and if the rapid is negative, then you go ahead and start them. If you don't have rapid tests in the clinic, then I would say you draw the blood, you have the patient come back in a week to start cabotegravir. In terms of continuity of care, we sort of had made the same recommendation in the guideline, and that is you can use a rapid test to determine status to continue somebody. Go ahead and give them an injection if they're rapid test negative, but then also send the blood to the lab so that you can deal with them appropriately if they have acquired HIV infection.
No, thanks, Dawn. I think that's really helpful to hear you sort of talk through that workflow. And just to be clear, the FDA prescribing information for Apretude does require or does say that you should use an RNA assay that is FDA cleared for acute infection or diagnostics, which kind of limits you to 2 tests only. I hear you sort of saying the same thing. You keep saying the qualitative test. Is that what CDC guidelines also endorse, or is there leeway for using a sensitive quantitative viral load test as we do in monitoring of people living with HIV, or is there a preference for, as the FDA has in the prescribing information, the ones that have clearance or approval for diagnostics?
So there's two parts to that question. We in the guidelines, we prefer qualitative over quantitative, but we do allow quantitative. So it will often say qualitative and then quantitative in parentheses, because we recognize that some people prefer whatever is the reason quantitative essays. The issue of an FDA approved test is really, clinicians don't order a specific platform. They order a test, and then the laboratory conducts the test using whatever platform they have. And I would guess that if you order a qualitative viral load, it's going to be done with an FDA approved platform. So I think we don't, at the provider recommendation level, we don't get into that, because I don't think the normal provider would say, do it with this technology versus that technology.
No, that's really helpful, because for the longest time, right, we only had, the one qualitative test that was approved, and it was a significant cost difference from quantitative RNAs. So I think that perspective is really helpful. I do want to be respectful of everybody's time. We are at the bottom of the hour, and I know folks have to run. So I apologize that we weren't able to get through everyone's questions. We'll try and get them written down and get back to you offline. But Dr. Smith and Dr. Daskalakis, thank you so much for spending 90 minutes with us today to go over these recommendations, this perspective, and answer everyone's questions. We really appreciate it. And I will turn it back over to our IAS-USA colleagues for closing thoughts.
Thank you, Dr. Daskalakis and Dr. Smith for a very informative webinar, and to Dr. Landovitz for moderating the Q&A. Just some closing information: evaluations and information on how to claim CME and credits will be emailed by 5 p.m. tomorrow. And here is a list of our upcoming webinars. And next week, we do have the CROI 2022 update with Dr. Buchbinder. And we have 2 live courses, one on April 8th in Atlanta, and then one in New York on June 13th. And you can find all of this information on the IAS-USA.org website. We also have a COVID-19 What We Know Today dialogue on Friday, April 1st. And again, I want to thank our presenters, Dr. Daskalakis and Dr. Smith, and to our moderator, Dr. Landovitz, as well as to the audience for your participation. Thank you.